Dr. Okwo, are we ready for the second technical session? Okay. Thank you. Thank you very much, Prof. We are really grateful for having had you with us here. If there are no other questions for Prof, at this point, I think it will be a good thing. Thank you, sir. We are really grateful, and we want, on behalf of THT and the entire network of providers, we want to say thank you for availing us of your presence and reassuring us that Lagos State has put in place and continues to put in place all that is necessary to contain this, this outbreak. Thank you, sir. So we go into the technical session on screening and isolation. Thank you. Yeah.
All right. Yeah. Are we ready? Can you show the screen? Okay. Yeah. Thank you very much for the interesting discussion so far. And the next presentation has really been preempted, which is what we expect every, can you show the full screen? Which is really what every health facility should really be doing at this point in time, which is ability to screen for COVID-19, ability to isolate suspected cases of COVID-19, and knowing the channel or the avenue for notifying public health authorities of such suspected case so that immediate action can be taken. And like was discussed earlier, we are really at the front line of this response right now, because it is to our clinics, to our hospitals, to our health facilities that the sick people will present. And for the private facilities, we are very mindful of the fact that over 60% of healthcare in Nigeria is provided by the private sector. So you share a huge, you really take care of a huge chunk of the Nigerian population, and high index of suspicion is very critical. So what do we mean when we say we want people to understand, screen, isolate, and notify? Next one. Go back. The next slide. Yeah. Sorry, we have, yes. So first of all, in this COVID-19, from what we know about the epidemiology in Nigeria right now, there is no community circulation. There's no community transmission as at now. And that is why one of our key objectives, one of our key goals right now is to try as much as possible to prevent community transmission. And what we mean by community transmission is a situation where it is now being transmitted from people who have no link to people who have gone to China, or people who have gone to any country or any place where this is known to be circulating already. We want every case, any case that we get now, to be a case that is linked to a travel to China or travel to any of the locations, any of the countries where this outbreak is currently on, but who we are able to quickly identify and then take out of the system per se in such a way that that chain of transmission is broken. This person doesn't start community transmission. That's one. The second aim is that when we are able to do that successfully, to identify this person and move the person out of circulation, we also want to make sure that the health facilities do not become the point where this infection gets amplified. Meaning, while we are keen to identify this, we also do not want infection to continue to go on in the health facility. And that is why, apart from screening, isolation, and notification, we have to apply standard precautions for all patients at all times. And then when we know or we suspect that this is now COVID-19, we then add what we call additional or transmission-based precautions, some extra precautions based on what we then understand the mode of transmission of this COVID-19 agent, which is the SARS-CoV virus to be. And added onto that is the implementation of administrative control and using environmental and engineering controls that we've discussed before. And that brings us to what is the case definition for COVID-19. Every healthcare worker in Nigeria right now should understand and be familiar with the case definition, the current case definition of COVID-19. And why I use the word current is that this case definition sometimes it might change if the epidemiologic situation changes. But for now, immediately after this, we will share with you the NCDC document that clearly defines and stipulates what the case definition of COVID-19 is. Okay, next one. So we have to be very familiar with what is the suspect case, who is a contact, and all that, because that is what will be helping us to do the screening, identification, and notification. Next slide, please. The next one. The next one. Okay, so what is the foundation and the basis for screening for COVID-19? It means that everybody who has contact with our health facilities this period must be safely screened for this disease. And mind you, I use the word everybody, not necessarily patients, because you can have a visitor or a patient or somebody who brought a patient to the hospital could also be somebody who could bring COVID-19 into the health facility. So it means every patient, visitor, caregiver in every health facility, there must be a system of screening for COVID-19. And screening them means that there could be some people who would flag as suspect COVID-19 cases. Therefore, every health facility also should have the ability to safely hold this person for some time. That means isolate this person from other people in the health facility for some time while they notify the public health authorities, who will then come and take it up from there. We heard what Prof has explained. Same would apply all over Nigeria. But we also want to know that for right now in Nigeria, based on the risk assessment, Lagos is the only place where there's a case. Therefore, every health facility would help us to keep watch so that if for any reason another case shows up anywhere in Nigeria, a vigilant healthcare worker who works in a prepared health facility, whether it's in Kano, Kaduna, Ilori, Enugu, Asaba, it doesn't matter where, a health facility that is prepared and has set up this screening system would have picked up this suspect case, notified the appropriate authority, and will quickly mop up that particular case. So that is the foundation of screening and the basis for which we are encouraging and telling everybody to set up this screening. It might seem as if you are looking for a needle in a haystack, but understanding the epidemiology of this, they will be the best use of resources. Because like I said before, we do not want this to start circulating in communities because it has huge and different implications if we start having community transmission. Next point. So we are working with NCDC now to develop some of these things into workplace reminders. Once that is ready, we will share it with you, the soft copies, and then you can print and make them available to every health facility. So screen for the disease, isolate from other patients, notify right authorities. So this should be the mantra now in every health facility. We are screening for disease, we are isolating, and we are notifying right authorities. Next slide. So what are those things we are screening for? We are looking for temperature check. We are looking for the symptom of dry cough, difficulty in breathing, and these are all the things that are in the case definition. So these are the symptoms. So we are screening for symptoms, meaning we are asking questions about symptoms. Okay? Taking temperature checks, the next one. Those are the screening points. Then we are asking, Then we are asking some questions about relevant exposure. Because for us now, in our situation in Nigeria for now, every case in Nigeria, if there's any case, will still be linked to a travel. So that is why case definition still says any recent travel within the last 14 days to China, close contact with any confirmed case of COVID-19, or exposure to healthcare facility in a country where hospital-associated COVID-19 infections have been reported. So these are just brief question would ask everybody who comes into the health facility and has a temperature and has the symptoms. So are we seeing the link now? You ask the questions around the symptoms, take a temperature check, ask about fever, ask about cough, ask about the respiratory symptoms, and then ask about history of exposure. Okay? And we added the close contact with the person who just came back from China in the previous 14 days. So these are the things that people must be screened for before they even move in to do the very first thing they came to the facility to do. This shouldn't be happening after somebody has registered, collected their cards, and they're now waiting in the waiting room. No, this is like the gatekeeping function now in the health facility. Because once a suspect case or a confirmed case slips through this screening and enters the health facility, it continues to increase the chances of every other person who came into that health facility to access care. So this is what we want every health facility in the country to help us to be looking out for. And this is what will pick out for us any other suspected case or any other case we'll have in Nigeria. This will be very, very critical in achieving that. Next one. We've developed this screening register just to help people think through, because most times when you tell people use case definition, they wonder, so how are you going to use it? So we'll share this eventually for people to use and just rule the lines in your notebook. These lines will just be ruled in the notebook, and for people, whoever will be at the screening point, just ask the, so take temperature. Do you have cough? Any difficulty in breathing? These are the symptoms and signs. Then exposure history. Then you can look at some of the comments. When somebody has signs and symptoms and no exposure, this is not COVID-19, most likely not. If somebody has exposure only, that person qualifies as a contact. So if somebody tells you, yes, somebody just came back from China, or I flew in the same plane as the person that came, so that person is a contact. If somebody has signs and symptoms and also has a history of exposure, that person then is a suspect case. Next one. Okay. And therefore, the question is, go back to, if it's a suspect case, what next? If this person, anybody that becomes a suspect case, should then be isolated in a holding area in the facility. And what this then means is that every facility right now, as part of their administrative measures, should identify a room, a space, or a section of their health facility where they will use to isolate any suspect case that they could have. This is not what you begin to think about or do when you already have a suspect case. These are some immediate decisions and actions that you need to take immediately after this phone call if you haven't done it already. And these are part of what we are checking in the readiness. We are asking people if they have in the readiness checklist that we shared. Some people may not have big space for this, but it doesn't matter the size of your space. All you need to do is think about your local concrete situation, use first principles to take some decisions. And once this patient has been isolated and the appropriate authorities have been notified, and the appropriate authorities being your state epidemiologist, the disease surveillance and notification officer of your local government, these are and Nigeria Center for Disease Control, these are the numbers everybody at this point must know, and it must be significantly displayed in every part of every health facility, so that whether it is a midnight call, whether it's an afternoon call, whether it happens during the weekend, Saturday or Sunday or public holiday, it doesn't matter. Everybody has access to the numbers to call, both numbers of the people in the health facility and people who are in the local government and people at the state level and at the national level. And once that call is made, somebody will come to help in collecting the specimen and in quickly testing, and then it will then start the next line of actions. And immediately, once somebody flags off as a suspect case, the immediate thing that needs to also happen is that contact Information about the person's contact should be collected immediately by that health facility immediately. Somebody is asking which specimen is to be collected. Most the specimen really will be oropharyngeal and specimen through the airway. But the lab people will do this in conjunction with this DSNOs and the state epidemiologists. You wouldn't be needing to collect the specimen yourself. The next one. But what every health facility can do is to help to take list of contacts. Immediately somebody is a suspect case, must collect as much information as possible from the person and take note of all the people that have had contact with this patient. So that's why we say if patient has symptoms and exposure, move patient to a holding area, notify authorities. But if no symptoms, let this patient continue to do whatever they came to do in the health facility, but mindful that it doesn't matter what care you're providing, standard precaution applies at all times. And I can assure you that almost all the patients you will be screening and seeing would have to continue the care they come to receive in your facility. But we are just using abundance of caution to meticulously look for that one case wherever it will arise in Nigeria so that we'll quickly take care of it to avoid, like I said, community transmission. Next one. So, how do we isolate? For suspect cases of SARS-CoV, about SARS-CoV is 1, you avoid contact. Remember, we said that droplet coming close to this patient, things can fall into your mouth. So avoid contact. Stay at least 1 meter away. Avoid body fluids. Use standard barrier precautions. And one of the standard barrier precautions you can use here is giving such a patient now a face mask to put on. As part of breaking the chain of transmission, it is what we call source control. Because when we put a face mask on this patient, we are covering the portal of exit. But when I say face mask, I do not mean an N95. I mean the surgical face mask, the common face mask that we use. And we should always know when in doubt, you can always ask for help. The next one. So, what are the specifications or some of the considerations if we are thinking about where to use or how to set up an isolation or holding area? The ideal isolation or holding area where you should be looking out for your health facility should be at least a single room with its own dedicated toilet, with windows that open to the outside and doors that close. And you do not want the doors to lead into corridors or for air to move from the windows to the corridors. You want air to go from the corridors out through the windows. But sometimes we realize that depending on the numbers, a single room may not be available. In that case, you can place, but this is really not, I don't see this happening for us at this point in time because we wouldn't be having so many suspect cases. But if really for any reason, we need to put 2 individuals who are suspect cases in the same room, we must make sure that those people have similar symptoms, but we must ensure that they must be separated by at least 1 meter, however you're situating them. There must be a 1 meter distance between their beds. Because it could turn out that one is a suspect, 2 people that are suspect COVID-19 cases, one may turn out to be confirmed, and the other one may just be having any other respiratory symptom. But, with even the history of exposure, but it could turn out that it's not COVID-19. But if this partial separation has not been maintained between the 2, even in the period that you're trying to investigate and find that you could get one person infected. So that is why it's important that we maintain the principle of distance. And we, as much as possible, must cordon off this area if we do not have like a door. But whether we have a door, we must put a no entry sign, and non-essential staff shouldn't be going there. This will not be the time for cleaners to go buy and recharge cards for the patient in there, for visitors to be coming to see the patient, or for every healthcare worker to go and see the patient. And this means there has to be a dedicated healthcare worker who should be, or workers who identified should be the only people that should have access to anybody who is in this isolation area or holding area. Next one. But sometimes we don't even have what meets all these specifications. We may not have an isolation room because of the size of your facility. But we must still be able to separate these patients when we identify them. But I can assure you that whatever space exists, you can adapt it if only we can think from the basis of good or first principles. So the picture I'll show now is a picture that of an isolation area that we developed during the Ebola EOC, because the same principle had to apply. So you can see that this is just a health facility that doesn't have space for where they can set up in a proper room as an isolation or holding area. But you can see that by just ingeniously arranging seating arrangements, we created a holding area that somebody can comfortably sit and wait for a couple of hours while movement and transportation to treatment centers can take place. So we keep showing we show this picture just to make the case that everybody must try to identify how to set up a place to isolate or hold. You can also use what do they call it? These screens to screen off this area, and people won't even see what's going on behind it. Go back to the other slides. Let's look at something backwards. So what are those things you can, in setting up a holding area? You have a room or rooms, depending on the size of your facility and the traffic. You may consider having more than one room and as isolation room. But I'll also point out that it doesn't necessarily mean that this isolation room should be vacant and empty and waiting for a suspect case. I'm only saying that your system must have a protocol for activating the availability of this isolation room immediately a case has been, you have a suspect case. So you can have this room dedicated that, yes, it must not be, patients must not be put in this room unless it becomes absolutely necessary, one. But even when we put patients there, once you have a suspect case, you have a protocol for quickly emptying this room and using it as an isolation room. So these are some of the administrative decisions we have to be taking now. Then we have to restrict access and screen patient off. Outside the room, we must make available some basic PPEs like your gloves and masks. You can see here that we do not put full body PPE and all that, because based on our principle of risk assessment, what part of my body is going to be exposed is what will help you to choose which PPE to use. And at all times, maintain distance of at least 1 meter. Hand hygiene must always be done, and there must be staff dedicated to this person in isolation, and this staff must not be working in other parts of the health facility for as long as they're taking care or overlooking this patient in isolation. And you must keep a register of every staff who has or has anything to do with this patient, including visitors, any visitor this patient might have, but we discourage visitors at this point. The next one. Next one. You can see here an example of a register that records anybody that has access or any interaction with this patient, the name, which procedure, what was done for this patient. So it's something like, came here, get patient food. It's something you've done for this patient. Get patient medication, get patient water, check patient temperature. So there can be so many things you can be doing for this patient, even while this patient is in isolation. Because remember, the chances that this would be a confirmed case is very low, but we still have to operate a high index of suspicion. And therefore, we must not lose track of the fact that this patient legitimately came to seek health care, but we have applied certain criteria that have singled this patient out as a suspect case. But that does not mean this patient cannot receive at least some care to keep him or her stable. And that is why this dedicated staff should at least do some things. If it's to give anti-malarials, if it's to give pain medications, to give fever, something for fever. But such a patient must receive care, but with standard precautions and transmission-based precautions applied to that. But whatever we do for this patient, we must record fully. Because if this patient turns out to be a confirmed case, we would like to also use this register to know what level of exposure, what level of interaction, what type of procedure did each healthcare worker do for this patient to help us categorize the degree of contact. Next one. So that's a continue. We've moved on from this. So same here, we've said before. So like I said, go back. Notification is essential to get suspect patients the care they need in an isolation ward. For now, for Nigeria, we have taken the decision that every case must be managed in a treatment center, in identified treatment center. And the reason is that we are not having community transmission at this point, and we want to keep it at that. We want every patient to quickly be taken out of circulation and managed where he receives safe care and away from other people that they can infect. So notify for record purposes. You also notify to get quick transfer for this patient to an isolation ward. And who are those people that you have to notify? The Nigeria Center for Disease Control. You have to notify your district notification, disease surveillance and notification officers. The state epidemiologists you have to notify. So there are so many numbers. The director of public health, everybody now, apart from this situation we are in, every health facility must, at a minimum, have the phone number of their disease surveillance and notification officer for the local government in which they operate. Every health facility must have the phone number of the state epidemiologist in the state where they operate. And then it is always good to also have the phone number of the director of public health. And the Nigeria Center for Disease Control phone numbers, everybody must have. Because remember, apart from COVID-19, there are actually so many other diseases that are of public health interest, which that are supposed to notify in Nigeria. Okay, next one. And we must remember, when we look at the chain of infection, remember patient environment, and because this is droplet, the patient environment will usually have a lot of the organisms in the patient environment. So we must always clean and disinfect patient environment. Once the patient leaves that place, it must be rendered safe again for the next patient if there's any need to take in any patient. And we must not forget the high touch surfaces around the bed, the light switches, the door handles, the bed frames, the drip stands, the monitors, anything that can, any surface that we keep touching, the call buttons, these are high touch surfaces. We must not forget them. We must clean them meticulously. The next one. Okay, continue. Okay, continue. These are just, when you get the slides, you can read up these ones. Okay, so go on. Go on. So, go back. So what is the point you are saying? We're saying right now, in every health facility in Nigeria, we want everybody to be implementing the screening for cough, respiratory symptoms, and travel history at the entrance to the facility, clinic, casualty, or hospital. So identify all the entry points in your health facility. For large teaching hospitals, it could be the medical outpatient, surgical outpatient, all the different points of entry to access care in the facility. We must situate the screening point. And we must be mindful that this screening must happen before the person has ever first contact with anybody in the facility. And it's good to put up a sign asking persons with a travel history in the last 14 days to identify themselves to staff. We also have to have provision of surgical masks to patients who are sneezing or coughing. And as much as possible, as part of respiratory hygiene and cough etiquette, we must see patients with respiratory symptoms regardless of what it is. First, that is part of standard precaution. Respiratory hygiene and cough etiquette is coughing patients, sneezing patients, quickly feed them so that you move them out of the system. And we must encourage hand hygiene, both among patients, healthcare workers, visitors, at all times. Next one. So what is our key message? We are still in the business of providing healthcare, let's not forget. And the chances that that a patient with COVID-19 will come to our facility is really very slim. So don't turn patients away. Rather, let us triage all patients and all visitors to our health facility. And what that means is we have to look for symptoms, combine it with exposure, and take a decision whether this meets the case definition of a suspect case. And once this person meets the definition of a suspect case, we move the person to the identified holding area for isolation, and then notify the appropriate authorities. And in all these things, we must remember that we protect ourselves. Distance is always our friend, 1 meter, and appropriate PPE based on a risk assessment. Next one. Yeah, so that's it. Yeah, I hope that was helpful.
Yeah. So much. Dr. Tochi Okwo from the Nigerian Center for Disease Control. That was insightful. I have healthcare workers with me here in the office, and they're so, it's so insightful. And I think that we're all more confident, of being able to actually mount a response and, in terms of preparedness. And I think that is the same feeling through all of the participants on this webinar. And I know that the numbers are going down, but I guess it's also because of the understanding that they will eventually, we're doing a recording and everybody will eventually get it and will disseminate it. Thank you very much, Dr. Tochi Okwo. I just want to notify us that Prof has graciously stepped out. He was with us all through this period until about 5 minutes ago, and he brings his well wishes again from the Lagos State Emergency Operations Center. So we quickly, a few more questions, and then we do a close and wrap up. So Dr. Gideon says, Dr. Tochi, you were indeed very helpful. Your presentations were super informative. Yeah, that is from our head provider management here. So one a particular question. Good evening, everyone. I would like to know if the question, that is the question around exposure, around traveling to China in the last 14 days should be asked. I believe questions regarding travel to countries on the coronavirus map should be asked, not limiting to China alone. Dr. Tochi, that's for you. Should we limit travel history to China alone, or like in the case, in our index case, it was an Italian. How do we marry that? Okay.
Yeah, thank you very much, and thank you, Gideon, for such gracious words. Thank you so much. Very valid observation and very important question whether we limit it to China for now. And I will state that the case definition is not cast in stone. It keeps changing as the epidemiologic picture globally and nationally and even locally as it evolves. And I'll tell you, as we speak now, our surveillance team in the pillar, we are constantly looking at the developments and modifying the case definition. So I won't be surprised if we receive a guideline very soon that has modified this case definition. But remember, index of suspicion should be what should guide us at all times. And we are experts in our field. We are experts in our own local circumstances. So please, case definitions are to guide us. If we think it will help us in refining our screening, adding some of those ones, please, using knowledge that we have, we can add it into our own local screening while we are still bringing out more guidance on the case definitions. But it is indeed a very valid point that has been made here. So it is not cast in stone. It is a value judgment. It is really, what I'm sensing, what I'm feeling. Every other thing you see provided is a guide. So if somebody has had a travel history, even if it's not to China, and I will even say, even if it's not to any of the countries that we know already that has reported a case of COVID-19, but your index of suspicion as the healthcare provider is high, please activate notify, and we'll all deal with it together. Because when you notify, people will come and take samples, and then we can confirm. Okay. Thank you.
Thank you, Dr. Tochi. So the idea is we're clinicians in our own right. The protocols and guidelines are what they are, and we can, with the high index of suspicion, we can as well exercise our judgment based on the history we have taken, and of course the case definition as well. So another question. Great presentation. Thank you, Doc. My question, please, where exactly do we start our screening? In the hospital? Is temperature screening at the gate appropriate? Then another question. Thanks, Dr. Tochi. How long can the virus survive outside the host? Two questions, Dr. Tochi.
Okay, thank you very much for the questions. Let us think what we are trying to achieve by screening. We are trying to make sure that before a suspect case who could potentially become a confirmed case has access to any of our services or anybody in our facility, that we are able to use this gatekeeping function to identify the person. So I cannot prescribe for you exactly where in your facility where you set this up. That is why we encourage every administration now, every healthcare provider to form a team, do a walkthrough survey, do an assessment of your facility. Where are those points that people access our facility through healthcare through our facility? That is where you situate your screening points, because the whole essence of screening is both visitors, both patients, both patient relations. Because I tell you, somebody that's been attending antenatal in your clinic all this while could have traveled abroad over the last 2 weeks or a couple of weeks and is back for her routine antenatal. So that this person is coming for routine care does not mean that this person cannot be a suspect case. So that is why that screening is there. So you have to identify whichever part of your facility that people must pass through before they do the very first thing, business that they came to the facility. And usually my understanding is that the first business is usually, getting themselves into the system through maybe getting a card or registering or documenting their presence. So I would say that gate is good if you're able to set up something at the gate. But even if it's not at the gate, the person, we are saying people should not have interaction with patients, healthcare worker, or any part of the system until they have been screened. So if your screening will mean emptying a whole section of your facility and everybody passes through there before they distribute to whatever part, it is your judgment. But just apply the principle. That's what is important. For the second part of the question, how long does this virus survive outside the body? I would say, first of all, every day research is coming out. But from what we know about other viruses of this category and some other ones that's already been observed in this current outbreak, it can survive for up to 9 days outside the body. But it even depends on the ambient conditions and the situations. Some people have even postulated that can last for up to 28 days, depending on where, but it really can last outside for about 9 days. And this makes a strong case for environmental cleaning. We must keep cleaning the environment. So I hope that has answered the question and provided some clarity.
Very, very insightful. Environmental cleaning, frequent, clearing up of our surfaces. Thank you, Dr. Tochi. I don't have any questions or comments remaining, but for further information and in continuation of all of this, because we know that this is ongoing until we come to a zero level. So, with COVID-19, where exactly can we as healthcare providers continue to access information, training materials, tools, that are important in terms of our preparedness, our response, healthcare providers, where exactly you point out.
Okay. Yeah, thank you. Before I answer the question, we will project the NCDC phone numbers. The NCDC website is always, keep going, let's say, okay, so on your screen now are the NCDC contact information, the phone numbers, the email addresses, the social media handles, everything. The Connect Center is on 24 hours a day. We are constantly monitoring, even monitoring rumors. And what we encourage everybody to, once you see anything on Facebook, on social media, once you get any information, please go to our website and verify. There's a lot of conspiracy theories going around. There's a lot of rumors and wrong information. In fact, part of the main epidemic we are having in the world today is the epidemic of infodemics, the epidemic of rumors, epidemic of rumor mongering. That's really one of the true epidemics we are having. And what we are begging people and asking them to do, the NCDC is a very responsive organization. The Connect Center is there. If you hear any rumor, call the Connect Center. If something is not clear, call the Connect Center. If there is a question you want us to look for answers to, because we also understand that this is new. We are learning as you're learning. Please, if there's anything you want us to look into, call the Connect Center, call this number and say, I want you to look into this. Consider this. We are really, really in this together. So that's why we say, everybody, let us identify where we fit in as solutions for preparing for and responding to this outbreak. And these are the contacts for the Nigeria Center for Disease Control. Secondly, the phone numbers, like I've mentioned, of your disease surveillance and notification officers, the phone numbers of the state epidemiologists are very important. And I will share briefly one key result of the readiness checklist that we've shared already, showing how many people know some of the very important phone numbers that we've been saying since. Just show that screen of which phone number do you know? Keep going. So we see so many people do not have IPC committees, so many people do not have IPC focal persons, so many people, so many things that so many health parties do not have. But that is exactly why we are doing this. You can already begin to see where people can make changes. But let's look at this. Let's only that one, which of the numbers. This is responses from, for now, the 101 responses from health facilities across the country. But you'll notice that 27% know the Nigeria Center for Disease Control phone number, which is very low. But NCDC is a national agency. Let's now look at how many people that know the phone number of their disease surveillance and notification officer, 11.9%, which is so low. And it is the disease surveillance and notification officer who will immediately, who is at your local government level. She's the person who enter an Okada immediately and come to your facility. She's the person who enter a Keke Mawa and come to your facility. She's the person who come and take the sample. She's the person who call the state epidemiologist. But then let's even look at the people who have the phone number of the state epidemiologist. We can't even assign a percentage here because it is so low. So please, the first assignment we would like everybody to do in the health facility, this state epidemiologist, NCDC, your hospital contact person, the disease surveillance and notification officer, and any medical officer of health in your local government should be conspicuously displayed in every part of the health facility. Because this can happen at a time that the person that should be called in the hospital is in a wedding, her child's wedding, and her phone is ringing and nobody is hearing it. There should be numbers that people can call. Because we do not want a situation where say, we were calling, say, oh, I was at a wedding, I didn't even hear my phone ring for 3 hours. And people say, madam, we kept her after they said, what are you keeping me for? They left. So please, what we are saying is that we must be very mindful of this disease notification system we have in the country. So first assignment, everybody, phone numbers of a state epidemiologist, NCDC phone numbers, the hospital phone numbers, not one person's phone number, somebody who can be reached over the weekend, people who can be reached middle of the night, people who can reach at all times of the day and all times of the week, then the medical officers of health. Other things, when this result, when we've collected this completely, we will share it with them. We'll try to, circulate it widely so that people can get a sense and a picture of the true situation in the country and help everybody to fill out, to begin to improve in their preparedness. And to also say that we are working on an IPC scorecard, which we consider to be a self-improvement tool to help people using a dashboard system to see where they are, whether they're in red, in yellow, or in green, with everybody striving to move from red through yellow and get entrenched in green, meaning that IPC is optimal. But once that is ready, we'll communicate it through the appropriate channel And that is why we'll be taking down, we'll be expecting the details and contacts of the people who have participated here so that they become part of our network. Any information we have to pass, any new thing, any important information, but I'm not talking about some WhatsApp group here. It's just that we know that these contacts are in our database and we can call upon them anytime we have key information that will be useful to them in helping to keep the nation safe. So thank you very much for your kind attention.
Yeah. Thank you, Dr. Tochi. We just want to, I think we are at a good point right now where we can call it a wrap. And on behalf of Total Health Trust, our healthcare provider network, the entire staff here, particularly our operations staff who have camped together with us here to actually make this happen for all of our providers. We just want to say thank you. NCDC, I just want to make a note here that this whole webinar was put together in less than 24 hours, and it is to the credit of the National Center for Disease Control that they decided that 5 p.m. today, we will have this webinar. That response could not have been better. And of course, it's just to show the commitment to this response and to the containment of COVID. So we do have a lot of thanks and gratitude that we want to express to the NCDC as an organization, and particularly to Dr. Tochi Okwo for the very insightful technical presentations. We as healthcare workers and as a HMO having access to this network, we will continue with these skills and knowledge that we have. We feel better empowered in the level of our preparedness and response to this outbreak, and we want to continue, and we also want to express our commitment, continuing commitment to take action as has been outlined to protect ourselves as health workers and of course to prevent any continuing spread and to prevent any community transmission. So thank you so much for all the participants, all the providers that came here at short notice. In fact, we had providers even coming into the live session center here with us in HQ. It just shows the level of commitment, healthcare worker commitment into seeing that we mount the kind of response that is required. So on behalf of the entire management of THT, we want to thank the Lagos State government, the Lagos State Ministry of Health, the Lagos State Primary Healthcare Board for being here with us, also in the person of Professor Akinyoshibogun. And to everybody, we just want to say thank you for being here with us. And I believe that this has not just added value to us, but it has taken us even one step further. It has leapfrogged us as a country and as a network of providers in terms of our readiness. And we will fight COVID, and COVID will not continue to be transmitted. We will halt it just in the same way that we were able to record success with Ebola, and that starts with us, and we feel empowered. Thank you, Dr. Tochi. Thank you, participants. In the absence of any other comments, any last words from Dr. Tochi, from NCDC? I just want to say today again that this session is recorded. We will be sending the copies to all of our provider networks, and so that actually you are able to do a replay and look at it again and take the adequate steps that we need to do. One thing I took away was the acronym. Even though it sounds funny, it's SIN. So yeah. Screen, isolate, and notify. So that is the way we're going to deal with our COVID preparedness at the facility level. Thank you so much. Dr. Okwa, last words.
Yeah, thank you very much. This is actually one of those situations where we are allowed to SIN. Okay. Yes, the acronym is actually SIN: screen, identify, and notify. And I would also like to thank you, Diola, for your excellent leadership. I'm not surprised. I would also like to let the providers know that our story didn't start today. She's an excellent person. She handed the baton to me so many years ago in one health maintenance organization. So I know the leadership she can provide. And the Nigerian Center for Disease Control, we are totally and completely committed to keeping Nigerians safe from these kind of situations. And we welcome every collaboration that we can have. We realize the value and the importance of people in the private sector. We do not take your contribution for granted, and we definitely understand the role you will play if we are going to be successful in combating this situation that we have at hand. We are very mindful that you're businessmen, and we know the kind of critical thinking you bring to things, your quick attention to getting things done, and that is what we are hoping and banking on, that people are going to take this and quickly turn it into a success story. So I'm very happy to have spent this evening with you. I know it is 2 hours well spent. It's really what I consider low cost, high impact intervention. And I'll be very happy any day to repeat this type of webinar, because we know how important these things are. So thank you very much, and have a restful night.
Bye. Thank you, everyone. Bye.
Bye.